righty. Everybody had a chance to get a seat and a mask if you want. One of the most defining features of humanity is our capacity for empathy, or the ability to put ourselves in other people's shoes. And it's that ability that we're questioning today, whether it's innate or is it acquired. That's the question our speaker will address. That was the introductory statement I prepared for our speaker, who was scheduled to give this talk 5 years ago. And then he and a bunch of us came down with COVID. And you know the rest of that story. For purposes of public disclosure, I should say that the speaker and I are co-fathers-in-law, co-grandparents. His daughter Jessica is married to our son Matthew, and Michael is in Seattle for the graduation of our granddaughter. Dr. Michael Goldberg is a pediatric orthopedic surgeon. He's retired from Tufts Medical Center in Boston and the Seattle Children's Hospital in Seattle. His major clinical interests are the diagnosis and management of children with genetic syndromes, complex birth defects, and skeletal dysplasia. And his research has focused on the question, are we helping and how do we know? He is currently Professor Emeritus from Tufts University School of Medicine and a scholar in residence at the Schwartz Center for Compassionate Healthcare, a national nonprofit dedicated to advancing compassionate care in healthcare and in caregivers. Please join me in welcoming, finally, Dr. Michael Goldberg.
Thank you. Is this on?
There we go.
No one's going to listen. Can you hear me even with that? Okay, is this better?
Yeah.
All right. So I want to thank you for. I've been privileged to be able to talk at during my career at many different size audiences, from small to big, and recently I was asked to speak at a group that was so small, even my host didn't show up. And so I had to introduce myself. And next to that introduction, Jack, this was the kindest introduction that I've heard. So we're going to talk about compassion. And I'd like for you to think about an experience you received or observed compassion in healthcare. And what did the person do that made the experience compassionate? What words were used? What behaviors made it so that you said, that is compassion, or that I felt compassion? So without any stories, but one word, how can you describe that experience? What did it feel like? What did you see? Yes. Caring. What else? It's kindness. Thoughtful. Connection. Interested. Warmth. Understanding. So, hopeful. So, we did a study at Schwartz Center of several thousand patients about what did they think compassionate care was. And patients reported that compassionate caregivers possess these qualities. And when I use the word caregiver, I mean anyone who touches the patient. Not just the doctor, the nurse, but the person who wheels you around or who checks you in. And what the patient said about the caregivers they encountered that they considered as compassionate, where they had empathy and kindness to me and my family. They had attentiveness and presence. They had understanding of my needs, my concerns. They were non-judgmental curiosity, acting in my interest, recognition of my uniqueness and context. So almost every one of the comments that they made, we started off that that's what you observed. So we have a sense when we are experiencing compassionate care, we have a sense of that person, what is missing and what is present, so we don't have to spend too much time. You're all experts in feeling this. So we then look at patients who said that their physicians had a lot of empathy. And we compared that to patients who described their caregiver as not being empathetic. And did it make a difference? And this study has been repeated over and over again. And what it said is that if we're looking at a group with diabetes, those patients who said that their physicians were empathetic, improved control of hemoglobin 1AC, lower cholesterol, fewer hospitalizations, better adherence to care recommendations, fewer serious complications. And the most interesting group to look at were those with cancer. And it found that when their physician and nurses were described as having high level of empathy, they had improved psychological adjustment and decreased anxiety. Decreased anxiety that was equal to or greater than Ativan and all the other stuff that we use for anxiety. Decrease ICU utilization at the end of life, dying at home rather than in an ICU, and even an improved immune response. So we know what compassion is, and here we know it works. So the critical question is, are we hardwired? So let's talk a bit about compassion. What it is it hardwired? Is it innate, modifiable? Why does it matter, in addition to what we said? And who cares? So first let's have a word about semantics. And the reason we do this is that when compassion, empathy is looked at from a scientific approach, it should have the same language that's used, although we may interchangeably use it. So how do we define sympathy, empathy, and compassion? Well, sympathy is the feeling of pity and sorrow for someone else's misfortune. I feel pity for you. I feel sorry for you. As compared to empathy is the ability to understand and share the feelings of another. Whereas with sympathy being for you, empathy is we, where I can feel and understand the feelings of another. And if we look at compassion, it is the deep feeling that arises when confronted with another's suffering, coupled with a strong desire to alleviate that suffering. Both those components are present in compassion. It is the feeling that you get when you see someone suffering and you wanting to do something about it. Reduce that suffering. So, empathy and compassion, however, is much more than semantics. It requires some cognition, emotion, and I'm going to now start the argument and the proof of that it is hardwired. So, many of you have had MRIs. Is there anyone here who didn't have an MRI? We know that what MRIs do is they show some anatomy, they show which pieces here and which pieces there, but it also, functional MRIs can tell by the areas of the brain what is happening, what is going on. So that if I was going to move my hand and I was in a functional MRI machine, you would see that just prior to movement, there's one area in motor cortex, and then I start the movement, and then the activity after the start of movement. So this function can be monitored by MRI, and so you know what is happening. In addition, the functional MRI can measure some emotional and other differences. So functional MRI of complex emotion has distinctive patterns for depression, schizophrenia, PTSD. You light up differently. And these are some examples of the various areas of the brain that's having emotional and working at a time when there's some psychiatric disorders. So, knowing that we can do that, what does the functional MRI show when you're experiencing compassion? And what happens is there's a discovery that there's a core neural network. And for those neuroanatomists in this group, it's in the anterior insular cortex, the anterior middle cingulate cortex, and it is there. We see it. We see it light up. And what is interesting, going back to our definition of compassion, empathy, the feeling you have when you see someone suffering, lights up one neuron over from your pain center. So what you're feeling is real pain. However, when you do something about it, when you reduce that suffering, the functional MRI shows that it lights up in the positive reward center. So, and this concept, we're going to see later in the talk about how it works when you are a patient or when you are a physician or caregiver. So we know that there's this core neural network and that empathy is lighting up when you see someone suffering in the pain center, and when you have compassion, there it's lighting up in the different area in the reward center. So, now if we possess a brain that is hardwired for empathy and compassion, there are a number of questions that come up. First, do we all have brains that are hardwired for empathy and compassion? Yes? No? No, I hear no's. Yeah. So, it turns out that people vary in their ability to experience and respond to emotions. But that's varying, is it? there or not at all. And what has been shown is that empathy really has two components. One, a cognitive or intellectual component. You understand what that person needs, what that person is suffering with. And secondly, an emotional feeling component. I know just how you're feeling. And while we all have this empathy and compassion with these two aspects, it's very different in the spectrum of humanity. Some people have more cognitive empathy, while others have much more emotional. We see this in nurses who get so involved with their patient that they get to be the patient. They feel with the patient. Their boundary between patient and caregiver is so intense in terms of their emotional feeling component. And on the other end are people who have only cognitive. They understand why you're suffering, but they don't necessarily have an emotional reaction. Can you think of anyone like that? Bernie Madow. He thoroughly knew what the population he was financial counselor for needed, worried, and then was able to embezzle their money. Intellectual component. Presidents, Clinton, I feel your pain. Did he really feel your pain? Did he? And our current president, he understood what people were suffering from. He understood what people were worried about. He understood the feeling intellectually of someone taking their job, someone not being inferior. Without being too political, I don't think he cared one bit. Zero on the emotional side, but enough cognitively to win the election. For those who have had experience with autistic children, they have tremendous emotional component. They hear a child cry, they're crying. They see something when suffering, they do that. It's emotional, but they do not have a lot of cognitive. They don't relate to what you're feeling and what you're doing. So we know that we're all hardwired, but there's different circuitry. Okay, can we teach brains to modify their structure so their owners can express even more empathy and compassion? Is what you're born with what you have? Is it just, I was born that way? Or can we teach brains to modify their structure and the owners can express even more empathy? So in this study, what was done, they took a group and they gave them functional MRI. Then they had training, specific empathy training. Then they did another MRI, and then they had specific training in compassion, and then they did an MRI at the end. And the control group went through the same sequence, except they had memory training. That was the only, they didn't have any empathy or compassion training. And what happened? Sorry. There were functional neural changes. related to empathy training, noted in the blue appearance, and compassionate training. It was increased to those compared to those with just memory training. So we can make functional changes in the brain with more expression in both empathy and compassion. Well, we know we all have it, and studies like this show that we can train it. Well, we know we can improve the function, but is it possible to make structural changes in the brain in addition to functional ones? And in a study by Engen and Bernhardt and Singer, these are the scientists who most publish in this area, they took long-term compassion and loving kindness meditators, and they compared it to someone who's never does any meditation or compassion type meditation. And not only did the brain light up more in these disciples of compassion, loving kindness meditator, there was also an increased cortical thickening in that area of the brain. Now you may argue and say, wait a minute, they were born with this piece that was bigger, and that's why they became great meditators, and that was able to do more compassion. And I think that's a very good criticism for this group. So then, let's look at it more specifically. Can targeted mental training make changes in different areas in the brain? And in this study, some 300 healthy adults, they performed specific daily training protocols, and we collected longitudinal MRI data over 9 months. They trained for mindfulness, for compassion, for empathy, and the cortical thickness, gray matter, where all this is going on, increased based on the module. So if you had no training at all during this time, just at the beginning, and then they didn't do anything for 9 months, you see the active area in blue disappeared. So everyone hepped up, but you don't keep it up, it doesn't stay as well as compared to module-specific training where there was a great bit more activity. So I think we could say we're all have wired, that it's different in terms of intellectual and emotional, and that we can educate or train for more activity and even perhaps for morphologic changes. But then the question is, do internal and external factors influence a brain that's hardwired for empathy and compassion? And this is probably the most difficult aspect to kind of wrestle with. There are both internal factors, and those are what we call unconscious bias. To experience empathy, one must value the distressed person. And other organizations and people have recognized this. That, for example, we value people who are suffering one at a time, not a whole group. If you watch TV and they're talking about feed a child, there's only one kid they show on the screen. Only one, hungry. An image of 1 million children starving in Yemen doesn't bring up the same response. That's our internal wiring. Look at the ad for St. Jude. One cancer child, one at a time. That's the way it seems to be as internal factors. We look at similarities and dissimilarities in people, consciously or unconsciously, and we definitely have more compassion for those we relate to in group. Most reminds them of myself. I say, I'm having a hip replacement surgery in a couple of weeks. And you say, I had hip replacement surgery. And then we did, where are you going? Where am I going? And great results, and I know just what you're doing. That understanding. Cataracts. Oh, there's nothing to it. We've all had our cataracts done. One day you can see better. And it works on the other side as well. That for those who you see as different, receive less empathy and compassion. And if you look at the huge disparities in care for those who are racially different, financially different, poverty, it is less. This connection isn't there. And this connection is very, very primitive. And it dates back to as far as you train history back. So I'll tell for reasons that remain unclear, our oldest daughter had gerbils that she raised. We had little fish tanks full of gerbils. And I noted that gerbil mothers ate other gerbil mothers' babies, but never ate their own. And this we've seen the naturalists talk about protection, mother lion and baby lion. The whole Walt Disney on Dumbo, all the music we all related to was Baby Mine. And that there is this primitive going back, and that is really one of the things that we have to kind of be aware of and address. That how we see people and how we evaluate is also our own awareness of ourselves. The similarity and dissimilarity in group and out group is there, and we have unconsciously stereotypes and bias. And that is a modifier of our hardwiring system, and one that we ought to keep in mind. And there are external factors, distractions, alarms, mobile phones, interruptions, computers. All of those distract while you are trying to deliver care that's compassionate. We know that for anyone who has had chronic pain and had pain therapy, that distraction was a key part of it. That you did certain exercises. You did things that would distract you away from the pain. It's fundamental in physical therapy treatments. Distraction of me while I'm with a patient shifts my attention away from the person's verbal and nonverbal expressions of distress. If it's shifting away my chronically sore hip, it's shifting away my receptor for emotion in the patient as well. And the disruption can be very short. And think about how many disruptions you're noticing when you visit healthcare. Endless ringing of bells, endless interruptions. When I was with a patient, try to look directly, there was a knock on the door. Could you please just sign this one order electronically so so-and-so can get their x-ray? Knock, knock, knock. There, Mrs. Smith is waiting. She just needs a prescription. Could you just sign this prescription? Every one of those interrupted me and took away the compassionate care I wanted to give. When I travel, I always took that little do not disturb thing from the hotel. I have a whole collection. And when I was here at Children's, I would put it on the door, do not disturb. But they caught on very quickly. And the only effective treatment, only effective sign that I was able to put up that had never disturbed is if I put a sign that said nursing mother. Because everyone relates to nursing. Oh, baby, we've got a cute baby. We don't want to disturb the baby thing. And then I can get through my appointment without a pound. So this is us. This is us, and this is how we're experiencing compassion, and we need to be aware of them. An interesting read is from a friend and colleague of mine, Helen Reese, called The Empathy Effect, and she talks a lot about this, including the primitive nature of some of the behaviors we have. Now it's a worthwhile read. And when this is becoming more and more recognized, there is actually parts of colleges and universities who are developing programs for both the medical and non-medical community. Compassion cultivation training from Stanford and cognitively based compassion training from Emory University. And there are some who are recognizing that this is important for incoming medical students and nurses and the like. So neuroscience and social science data support the concept that we are hardwired for empathy and compassion. We all have it. It can be taught. It is influenced by internal and external factors. So what we know is that the characteristics of compassionate healthcare provides hope to the patient, gives support to the caregivers, offers sustenance to the healing process, addresses the patient's need for connection and relationship, but it requires attentive listening, requires not being disturbed. It requires a desire to understand the patient's context and perspective. And it requires awareness of our own emotions and what resonates with us and what doesn't. And it demands a healthy caregiver workforce, which we don't have. Think about your last contact with the healthcare system. Was it compassionate? Whether you saw your doctor, whether you went to the pharmacy, whether you calling Medicare. Was it a compassionate encounter? Was it the ease of shopping at Costco? What was it like? And the lack of compassion in the health system is not a new problem. COVID did make it worse. But way back in 2011, in some studies that Schwarzenegger did, only 53% of patients and 58% of physicians said that the healthcare provided compassionate care. That is 15 years ago as we were having this problem. In 2017, 47% of physicians and 40% of nurses felt that the healthcare system provides compassionate care. This is your nurse. Only 40% of nurses say that they can go to work and deliver compassionate health care. In 2019, more than 50% of physicians, residents, and nurses reported symptoms of burnout. So here in the senior audience, you know just what's going on, what you're feeling, the computers and the interruptions, and the change from the relational aspects of patient care to the transactional ones. But I wanted to tell you that it's obvious to children as well. This is the drawing of our a 7-year-old, he told the pediatrician patient. And what you see here is here is the patient sitting on the table. Here is the patient's mother. Here is the patient's older sister holding the younger sister. And everyone here pretty smiling. And here, with his back to the entire group, is the pediatrician. So they're recognizing this young. No matter what ads you see, children tell the truth. So when you have burnout among physicians, it leads to depression and it leads to suicide. And burnout is actually an individual's response to work conditions. It's not a medical condition, it's a response of a sick workplace. Depression is a medical condition, and that's where the patient needs treatment. If not, it goes onto suicide. And not to be too grim, there's a very high incidence of suicide in the medical profession. It's 2.5 times the average population, and almost 4 times if you are a woman physician. Each year, each day, a physician dies by suicide. There's almost 400 a year. And the way you think about it is 400 is like the size of a medical school. 4 classes, 100 each. So it's like every year, a different medical school has everyone pass on by suicide. So it's a real problem. And it is one that many argue is not being addressed as fully as it could. And so, as we close, I want to go back to the first question. Is there a compassion, neuroscience, burnout connection? Are these all linked? And that if we focus on compassion and understand our wiring, that it will have a beneficial effect on burnout. So burnout, when you read about it and hear about it, is a mental state that's characterized by emotional exhaustion. I am emotionally depleted by my work. Depersonalization. They say, I see patients not as people. The broken hip down there, and we're getting who's coming in? A patient with asthma. Do we know anything about the patient? No. We know they have insurance, otherwise it wouldn't be coming in. But they have this depersonalization. And most importantly, there's a decreased sense of personal accomplishment. I feel ineffective. It's a very, speaking from experience, it's a feeling, it's not being inefficient. I saw all the patients in the clinic. It's feeling ineffective because I knew what those patients needed and deserved, and I was unable to deliver it because there was too much commotion. I had only 11 minutes to see them. The drug they needed wasn't available by their insurance plan. So at night, brush teeth at night, I didn't feel inefficient. I felt ineffective. And that's the core of burnout. Now, but what argument did we make? Burnout occurs when you know the patient's needs. The empathy pain center is turned on, but you are unable to give it to them. The reward center is turned off. So you have practicing with only the empathy center working, only your pain center working, and not give them what they need. You do not have the reward that comes with that. And often there are small things, as we mentioned, 10 more minutes in the clinic or at the bedside, a bit more patient education, medication tests and services not covered by insurance, consultants not available till next June, not this June, next June. That's when you get to see the neurologist you're waiting for. And some recent studies have shown that when there is compassion, it triggers many of the self-soothing physiologic changes. Heart rate goes down. The feeling of tension goes down. Some of the metabolic changes. So when you might read that people are burning out because there's so much need, they are having compassion fatigue. They can't keep up with the compassion that's needed. And I would argue that they're having too little compassion because they're not being given a chance to work on the other side of the hardwired section. And that is that to deliver the care their patients need and deserve. And that's how hospitals need to do it, and that's how we have to train our medical students. And we have to go back to being less transactional and work with the anatomy that comes into our office. So, in closing, I would say that compassion is more than an antidote for burnout. It prevents it. And I think when you receive compassionate care, you will see many of the benefits to your healing yourself. So, thank you all very much. And I was told I have to stop right at this moment, so it's up to you to ask some questions if we have some time.
I think we have a few people running mics around here. I'm reminded of something, your lecture, a quotation I once saw. It said, they'll not remember anything you said, and they'll not remember anything you did, but they will remember how you made them feel. Now, yep. Thank you. So do we have any questions? Oh, here we go.
I'm glad he's fast. I would have forgotten the question by the time he got. One of the things I've noticed is as I visit with my new physician, the other day she turned to me and said, "You know, I just love it when you come in here." And I say, "Why?" And she said, "Because you make me laugh." And I think part of our responsibility as patients is to remember the impact that we can have on our physicians in terms of their ability to care for us and to be compassionate toward us. So take your sense of humor with you when you go to see your doctor next time.
That's wonderful advice. Be civil. I had an interesting assignment which I thought I'd never see in my career, more than 50 years in clinical medicine, and that was, I was on the team to write up a sign that would be where the patient check-in would be, that said, to be civil. Don't scream at the person who's checking you in. No physical violence. Like, wow. It's no different than a sign you might put anywhere else in our current, the lack of civility. Violence in hospitals now, patient staff violence is at a new high. So they should listen to your advice. It should be a big sign on I-5. Be nice.
Okay, have a question back.
Just a quick comment based on a longitudinal study I've been doing recently. I've had the same doctor for several years. Excellent doctor, wonderful skills, always was a very good listener. He now has a computer.
Mm-hmm.
He sits most of the time typing into the keyboard, not looking at me. I know it's not the way in which his job has changed means I feel like I'm getting less attention. I'm sure his notes are exactly what are required of him, but his relationship with me has changed, even though his skill set is undoubtedly better than it used to be. Before the doctor saw me, I've been seeing doctors a lot recently. I saw one a couple days before I saw the doctor himself came. What are you here for?
Mike is cutting out.
Sorry. An assistant said, what are you here for? And sat to make comments to the computer to prepare for the doctor. At one point I was trying to describe symptoms, and she said to me, that's not on my list.
Yep.
So she had in front of her
Yes. So
we kept talking until I came up with a word that fit her list. The whole relationship had been changed by the obligation to make things fit their computer.
Well, it fits their computer because that's a billable topic. So just to take a brief thing, when I first started to practice, I had a medical record. I wrote things down, and it was a memory jogger. So if I saw a patient and I learned that she was applying to college, or that I saw that mother was pregnant, I'd make a note so that at the next visit I could bring up those things. But then the medical record changed. The medical record changed from what was a memory document to one that's to be used for billing mostly, and used for legal protection. And this was a seminal change. It meant that if you did not write it down, you didn't do it. It was this amazing change in trust of doctors and nurses. If you did not write down all these different conditions, you didn't ask about it. If you didn't write down ones that had a billing number, keep going. The medical records are loved by billers. Epic was developed as a billing system. And the importance of that became, boy, it was more important. Doctors changed. In a study that was done not so long ago, where they followed doctors around their office, they found for every 1 hour that they were face-to-face with the patient, they were an hour and a half face-to-face with their computer. It's commonly known. You make your notes at night. It's pajama work. And it's got billing. If I fall behind in my billing, I'll get a note instantaneously. It's generated. So, there's better efforts now, and maybe that the development of the the development of the systems are getting better. The use of computers are getting easier. I'm not a native computer, and it sometimes could lead to the discouragement you have and the head nodding that we see here, and so that's medical record change. I'm not allowed to call on anyone.
I want to report that my busiest health provider specialist now has a scribe.
Mm-hmm.
Terrific. I mean, she gets so much done, and also that I bring humor to my visits. Ask about their children. I know where they live. Not what house, but kind of like what side of the what. So I create a relationship with my doctors. But I think the thing that's so interesting is my health provider has changed the primary care's time from 20 minutes to 40 minutes. You can really have a visit in 40 minutes and talk about everything instead of get home and say, oh, I never mentioned this or this or this.
Yeah.
So I think it's Kaiser. Good, thanks.
So the points that were brought up are true. There are ways now with scribes to do things, and they're having AI machinery is now being tried. Listen to your conversation, and then they'll make up the note from that conversation. And for people who are willing to pay for concierge service, they'll have longer appointments.
I was going to ask, what's your sense of whether these problems, which are universal, everyone who talks about doctors comes up with these things, what's being done by medical schools and colleges and everything else to address this problem? Is it a problem that is considered something that needs to be worked on?
Well, it's hard to give a short answer to that. I think there is awareness. I think that there is priorities from hospital point of view is the marked disruption of revenue that happened during COVID, and that this is an important driver. There is awareness of in medical schools. How do you teach or develop a relational practice, a relation with patients as compared to a transactional one? There is more and more are being seen electronically by video, virtual presentations. I think that the first thing that's going to have to happen is to recognize that this is a problem. And although you notice from some of this data, it was collected 2 decades ago, I think there's an awareness now, finally, much more of an awareness that this is a problem and it has to be addressed. No, but I have no more specifics.
Can I talk about something that's not medical but empathetic?
Sure.
My job at Boeing was wonderful. I counseled relocating employees, and their life was so stressful. They're leaving a job, they're moving, they're going to a new job. Their family doesn't want to relocate. Their wife their spouse wants a divorce. I had 2 suicides. So my job was to get that employee to the new job with no stress. I talked and talked. I empathized. I just imagined what each one was going through at that moment. And like you, I would make little notes. Oh, your daughter got married. How was the wedding and everything? And I was hugely successful.
Yeah, so What you're describing is this idea that their businesses have recognized stress and burnout long before we did in medicine. If a stress burnout questionnaire, what many people fill out is now in the hospital, was developed by Maslach, who was developed it in 1967 for use in industry and social work services and other to measure the stress. They didn't call it burnout at that time. People have known, everyone I would argue knows that the experience of the worker drives the experience of the customer. And you know that when the difference renewing your license or shopping at my favorite Costco. But the experience of nurses drives the experience of the patients. And only recently has that principle, which has been known for years, been applied to medicine. And so it is learning new. Big companies like Boeing have been aware of this. Psychological safety, where your worker feels safe to speak about problems without fear of retribution. That was developed by Edmonds in the 1900s and wrote extensively about it in the Harvard Business Journal. So medicine is actually lagging behind the cultural awareness and what you described. And they tried to get it done through human resources. And that
Any more questions?
Now it's on, I think. You mentioned it, but I think it could have been emphasized tenfold. But I was interested that every one of the questions that has been asked today reflects the critical factor. Compassion and what's going on in the brain are products of things that are happening. Mm-hmm. And so the areas of the brain affected by various conditions are a function of something. And the question is, what are they a function of? And I think every one of the questions asked today had to do with the nature of the relationship. Mm-hmm. That you even mentioned that, you read about 100,000 people in Yemen going through a flood or something terrible happening, and you feel terrible about it, but 10 minutes later you're on to the next page of the New York Times. Mm-hmm. And it seems to me the critical factor is the nature of the relationship between the doctor or the friend or anybody and the person who is experiencing something. And it seems to me that compassion is a very important problem, but it's kind of a function of something. And what is it a function of? It's a function of the nature of the relationship between the person who has some kind of a problem and the person who is looking at the problem and who knows the person.
I think what you're saying is very true. So, I think that what you describe is how do some of these principles really work in the real world. And thank you for bringing that up.
I would like to make an observation. Although at my longevity of wisdom, I had never been hospitalized. I had never had any surgery or anything until the first week of this year. And so I was able to observe directly what I had been observing with my husband, who was sent from doctor to doctor or repeatedly to his wonderful internist. And towards the end, it all boiled down to, well, so-and-so, when we get to your age, and they might look smooth-faced and not shaving yet, when we get to your age, these things happen and the organs break down, and we've got to just kind of accept these. Well, after about the 8th or 9th time, I've said to this one doctor, Doctor, if you should be lucky enough to make it to 90 or so, and some young buck of a doctor comes along and says, Neil, when we get to this age, these things are going to happen. You're going to reach out and deck him. And the young doctor looked down and gave kind of a chagrined smile, and he said, I'll try to remember that, Carol. Yeah. And I said, I hope so. And I think it's a form of compassion to try to come up with a solution, and there isn't one. Just come out and tell us, here's the stuff. You can or you can't or this. But there is real ageism of a strange sort in the medical profession.
Yep. Oh, I agree, and I think you've raised a lot of interesting points. I want to be time sensitive. When I was an intern at Columbia Presbyterian in 1965, I was on the service of Dr. Cushman Hagenson, who was a famous breast surgeon. There was no chemotherapy at that time. There was no immune therapy. So breast cancer or any other was surgery, and if it didn't work, wasn't completely cured by surgery, there was an inevitable progression. And in fact, there was even a whole hospital, Francis Delafield Hospital, where part of Columbia, where the people went to die with their terminal cancer. And I remember him as if every day I have a picture of him. He would make rounds and sit down with the women and hold their hands and say, there is nothing more I can do for your disease. What can I do for you? And that pertains today. There's nothing I can do about your aging. But what can I do for you? And if we just make that, some people say they don't have time for compassion. I think that takes 12 seconds to say. But it begins to establish the conversation. So.
One more, is it on?
Sure.
It strikes me that as long as the health insurance companies have such control and are looking at the bottom line and what their stock price is, that it's not likely that things are going to change a lot.
Yeah. No one can disagree. If you look at, there was a recent article in the New England Journal of Medicine that looked at costs of healthcare and standard measurements of health in the country. How long you live, neonatal death, infection death, and the like. And you compared it to the Western hospitals, Scandinavia, Australia, Europe, Canada, and the United States came out the most expensive and came out the worst of all those monitors. It's the United States needs a cultural change and move healthcare to a right, to a requirement. And I think everyone feels the anger and frustration that with what you've said. So,
Okay, I think I see no more questions. Thank you very much, Michael, and
You're very
thank you very much for all attending. Thank you.
Thank you.